to the 2016 Coding Clinic Update webinar. I am Raylin Kishbaugh, Director of Customer Success from Wolters Kluwer, and let me go over just a few quick instructions on how to use the webinar system. Your line is muted, so if you have any questions, please use the Questions tab or menu bar item located on the GoToWebinar menu on the right-hand side of your screen to submit questions. The handouts are available. They can be downloaded. Select Handouts on the GoToWebinar tab or menu and just click on the link. We will also be sending out a webinar follow-up email within 48 hours, which will include a link to the handout as well. Today's webinar has been approved for 1 CEU from AHIMA and 1.5 CEUs from AAPC. An email with a survey and download instructions will be sent shortly after the webinar so that you can download that. With that logistics out of the way, I'm really happy to present Barry Libman, President and Founder of Barry Libman Inc. and Libman Education. Prior to forming Barry Libman Inc. in 1998 and Libman Education in 2012, Barry held a number of positions in the health information management field, working for hospitals, insurers, consulting firms, and regulatory bodies. Barry is recognized for his in-depth knowledge of coding and reimbursement issues for acute care hospitals, with a particular interest and expertise in long-term care acute hospital coding. Barry is often called upon to provide education and training on code updates and coding issues, and he is an approved AHIMA ICD-10 trainer, a graduate of Northeastern University, and holds a master's in healthcare administration from Simmons College. It's my pleasure to turn the presentation over to you, Barry, and we can go ahead and get started.
Okay, thank you, Raylin. To begin with, there's a little bit of coding news I'd like to review before we get into our coding clinic review. And first and foremost, at this point it's been about 2 months since this has occurred, but on March 9th and 10th, the Coordination and Maintenance Committee meeting met. Those sessions were recorded and are now available on YouTube and on links available through the CMS website. A couple of things happened at those meetings. On the diagnosis side and procedure side, we were informed of the new tables being available for the new diagnosis and procedure codes for fiscal year 2017. Those tables told us that, as you can see the numbers on the screen, 3,651 new PCS codes, 1,943 new CM codes, but also a number of codes with revised titles, which really means that that turns them into a fundamentally brand new code. So lots of new codes coming down the pike. I know that those will be posted on the Wolters Kluwer website when those tables are finalized. The other item that occurred, and it's primarily the principal use of the Coordination and Maintenance Committee, is to review proposals for new codes, and any of the codes that were reviewed those days are aimed to be given to us in fiscal year 2018. The timeline and the process is, unless it's urgent, as in the case of providing new codes for the Zika virus, which we're going to talk about momentarily, those codes occur in the next fiscal year. On the procedure side, the PCS side, there will be new for fiscal year 2017, new cardiovascular procedure codes, changes in the types of intraluminal devices used to repair vessels, as well as a change in the how the number of lesions that are repaired is going to be changed to the number of vessels in which the procedure is performed. On the diagnosis side, we have a whole range of pent-up demand the past 4 years of codes coming to us, and in fiscal year 2018 we hope to fix the problems with hepatic encephalopathy, a new code for recurrent C. difficile, and diabetic ketoacidosis. The 2017 guidelines have not yet been released. We checked the website this morning just to make sure that that would be accurate information. And keep in mind that while watching, you should watch, I recommend watching the YouTube videos for their educational value. Keep in mind that there are CEUs available for having watched those videos as well. Can guarantee that there will be a new code for Zika virus moving from A92.8 to A92.5. I've listed a couple of reading references this seems worth keeping up on the progress of the Zika virus and diagnosis and treatment of the virus. And at the coordination and maintenance meeting, as you will hear when you review those videos, the code A92.5 may change, may be expanded. There may be guidelines attached to that, especially as we come to better understand the association of the Zika virus with Guillain-Barré disease, complications of pregnancy, and congenital related infections. So keep that in mind as we go down the turnpike here. New proposed rule for fiscal year 2017 was published April 27th. I always recommend reading the Federal Register. The proposed rule is worth keeping an eye on simply because it does, as I mentioned, there's been pent-up demand for a number of changes over the past few years. But this one specifically goes into a lot of detail about the reassignment of certain PCS procedure codes that may not have been within the DRGs we had expected to find them. And there's a lot of discussion about either why they're staying where they are or why they're going to be shifted to another location. CodingClinicAdvisor.com. This is a relatively new process. Used to be when you had questions for Coding Clinic, you would either fax them or write a letter and send them in, and you would often wonder what became of those if you never saw your question turned into us, into them there. But this is a relatively new process. One goes online, one registers, you submit your request, you get a tracking number, and you get to follow your progress by logging back in to see how your question is doing. This is a big improvement over the old process, and I recommend that as questions come up, you utilize it. One never knows that the rest of the country also has the very same question you do, and the more frequently that question is posed, the more likely it is to receive a response. This is the current status of Coding Clinic guidance for ICD-10, and the reason we show this slide is to point out that while starting first quarter 2014, there was a Coding Clinic, one moment, there was a Coding Clinic that told us the title of the Q1 2014 Coding Clinic was, I'm not sure why we're getting this message here. Let's try don't show again. There we go. Was Coding Clinic for ICD-10. Try again. But keep in mind that there were 5 coding clinics in ICD-9 that contained Coding Clinic advice from ICD-10. And to remember that when you're looking at advice for I-10, to go back into that process and have a look at that. Really the point to make is that second quarter 2000, we're going to review first quarter 2016 today primarily, but the second quarter 2016 is due out any day now. The Coding Clinic transition. At the outset, there was first quarter 2013, which gave us the information that there were no plans to translate all previous Coding Clinic from 9 into 10, which many people, including myself, understood to mean that all of the ICD-9 Coding Clinics sunsetted and all the 10 would be new information that we were to follow. And that pretty clearly became realized that that was not a practical approach, and fourth quarter 2015 told us that in general, Coding Clinics that contained information not unique to 9 remain applicable for 10 CM with some caveats. So as long as there was nothing new published in Coding Clinic for 10 to replace the ICD-9 advice, the ICD-9 advice would stand, and that was very helpful and a very reassuring perspective. Coding Clinic goes on to tell us that previously published I-9 advice that is still relevant will continue to be republished in Coding Clinic for ICD-10, which is almost a contradiction of the previous slide when they tell us that if the old advice was worthwhile, would still stand, that we wouldn't need to be retold. But there are certain issues that were just so complex, and they wanted to make sure that there was a smooth transition, that we saw that it was published again in ICD-10, reiterating that it was valid from 9 into 10 to create a smooth transition. Let's take a moment and talk about the hierarchy of guidance. And as you can see, I've listed first the conventions of the classification, second the official guidelines, and Coding Clinic is really third within the hierarchy, and some information as to how we know that's the case. The official coding guidelines, for instance, tell us, as you can see, the instructions and conventions of the classification take precedence over the guidelines. therefore, the convention, as it says, the rules in the book of see also, code also, sequencing take precedence over anything that would be told to us in the guidelines. And very important statement is that adherence to these guidelines when assigning ICD 910 CM diagnosis codes is required under HIPAA. So there's so many reasons to follow the guidelines, but lastly, if you think there's any reason that you don't have to, keep in mind that that would be a violation of HIPAA. When one reads Coding Clinic, there's several themes that one should keep in mind. And the first is when you open a Coding Clinic to try to understand what are these questions and answers trying to tell us. And the information really takes a predictable pattern. First, we have the guidance that is the same as an ICD-9, and that is very reassuring. Then we have the guidance that is drastically different from 9 into 10. And that's always an eye-opener and gets our attention because we want to understand what has changed with respect to data collection and data reporting that would lead them to want to learn about these clinical circumstances in a different way. Next, we have corrections to the classification. Building a classification is a huge undertaking, and sometimes mistakes were made in the process. It was bound to happen. So Coding Clinic has stepped up and made some corrections and advised us of corrections to the classification. We have corrections to previous Coding Clinics, and like developing a classification, creating the guidance is a learning process, and sometimes mistakes were made, or we have come to a better understanding of the nature of how to use certain codes and certain combinations of codes, and Coding Clinic is now telling us that there are some corrections, and we will review some of those as well. A very optimistic approach is that some items in Coding Clinic are empowering. They're giving us, the coders, the ability to make decisions based on the information in the record. And then lastly, and this is a big improvement in Coding Clinic from 9 into 10, Coding Clinic has chosen to address certain complex issues with multiple examples and multiple bits of advice. Some of the examples you've probably noticed over the past several Coding Clinic issues are a number of Coding Clinics telling us how to handle reporting in the long-term care setting, or how to code mechanical ventilation given the variety of clinical situations one might encounter there. Debridement has a new number of Coding Clinics to address it. There were about 26 Coding Clinic questions to address the topic of how to assign seventh character for injury and poisoning and things of that nature. Most recently, procedure codes, a variety for how to treat cerebral hemorrhage and hematoma procedures, as well as this issue has a bit of guidance as to how to code obstetric procedures. So a big improvement when Coding Clinic takes a single topic and addresses it from multiple different perspectives. Today, these are the topics that we hope to have time to get through. Just wanted to give you a sense of the direction that we're headed in today. But first, we're going to start by talking about exclusion notes. And before we talk about exclusion notes and a Coding Clinic correction to exclusion notes, let's take a quick look at exclusion notes just to get some background before we jump into that. The guidelines tell us that there are two types of excludes notes that you're probably familiar with by now. And at the bottom of the page, I've given you the citation because I know you're going to want to go look these up and check the references for yourself. And here, the guidelines tell us that an excludes one note means basically that when you get to this spot, you should go find another code. Information included under the excludes one note tells you that based on the additional information that this isn't where you want to make your decision, you want to go elsewhere and choose a code from somewhere else. So an excludes one note means to go find another code. In comparison, an excludes two note means that you would use this code. That's what the phrase not included here is, that some aspect of the clinical circumstance you're coding is not included here, meaning that you would use this code plus an additional code you would go elsewhere to find. And what has happened is the National Center for Health Statistics has issued some interim advice, because what has occurred is they realized that in the development of the classification, some mistakes made in the creation of the excludes notes. I've always personally found the excludes notes very confusing, and apparently so did the developers of the classification, because as I mentioned, mistakes were made. This interim advice says that there are circumstances have been identified where some conditions included in the excludes one note might be better allowed to be in an excludes to note. However, the problem is that due to the partial code freeze, no changes could be made despite the fact that these problems with the excludes notes were recognized. So keeping that in mind, we're going to jump in and look at just one simple example of an excludes one note that was incorrectly written. And this occurs under chronic obstructive lung disease. And you see that most of the items below, these conditions are more specific and therefore would be correctly identified to tell you to go use another code. But at the very bottom of the line, lung diseases due to external agents, J60 through J70, aspiration pneumonia at code J69.0, there is no reason why J44.9 and J69.0 couldn't be used together. So that last line is an example of a mistake within the excludes one note. And I'm sure your work has already brought you to different places where you would already find those. And if you don't happen to be someone who regularly reads the NCHS website, Coding Clinic, working in concert with the cooperating parties, has chosen to give us an example question. We have received several questions regarding the interpretation of excludes one notes when the conditions are unrelated to each other, which is a contradiction. And the answer is, if the two conditions are not related to one another, it is permissible to report both codes despite the presence of an excludes one note, giving the coder, another empowering coding clinic, license to do the right thing and not follow the excludes one note when the information is obvious that it runs in conflict. Next, we want to talk about a very important coding clinic that talks about the foundation of documentation. And first and foremost, I mean, you know the answer to this even as you read it. Is there a guideline or rule that indicates you should only use medical record documentation for that specific visit, for diagnosis coding purposes visits? And even now, even from here, I can hear you all shouting yes. Does each visit or admission stand alone? Again, you're all shouting yes, of course. You know the answer to these questions. Would the coder go back to previous encounters records to assist in the coding of a current visit or admission? And the answer is a resounding no. But let's have a look at why this is the case based on the answer. The documentation for the current encounter should clearly reflect the diagnoses that are current and relevant for that encounter. It sets forth the documentation principle. The next two paragraphs talk a little bit about problems with the electronic, allude to problems with the electronic record, and that cutting and pasting sometimes bring forth historical problems that are not necessarily relevant for that visit. And lastly, it's the physician's responsibility to determine the diagnosis. It assigns responsibility. And next to the last line, the recurring conditions should be documented in the medical record with each encounter, and that's wishful thinking, but that is the way it should be, optimistically speaking. The real answer to this question is, however, if the condition is not documented in the current health record, it is not correct to go back to previous encounters to retrieve the diagnosis without physician confirmation. And a query would be sufficient. An appropriately worded, carried out query process could help you in that respect. The next paragraph, this is an area where really alludes to the need for physician documentation and tells us how to go about doing it. And lastly, that this advice applies to both ICD-9 and ICD-10 to provide, again, a smooth transition from reporting in 9 into 10, meaning the source documentation in 9 is the same as it is in 10, and that aspect has not specifically changed. So again, speaks to the foundation of the basics of documentation principles and coding principles. So we always start there just to get everyone onto the same page. Next, I want to start with a new topic, review of a confusing present on admission guideline. And this really speaks to the use of combination codes. And combination codes are, as you can see at the bottom, codes that contain two aspects of a condition, often the condition and the acuity of the condition, COPD with an acute exacerbation. One can report COPD, and one can also report that with an exacerbation. One can report gastric ulcers, and one can report bleeding gastric ulcers. And again, asthma with status asthmaticus, acute and chronic renal failure is an example, acute and chronic diastolic systolic congestive heart failure. So what happens is This rule tells us that for present on admission reporting, that you assign the character N for no if any part of the combination code was not present on admission. And the reason we talk about this is that we find that in the course of reviewing coders and doing education, that this is a particularly difficult concept because it may feel counterintuitive, but if someone is admitted with chronic obstructive lung disease, and you can see where this is going, and during the stay an exacerbation arises, it was not present on admission, then because a single part of that code was not present on admission, the present on admission indicator would be reported as no. The same for the gastric ulcer. And gas patient has a known gastric ulcer that bleeds several days into the hospital stay. It was not bleeding on admission. You get the idea. This would also be a present on admission indicator of no. So with that under our belt, we're going to go look at an exception to this guideline, and that really occurs under pressure ulcer with progressing from stage 2 to stage 3, and this was reviewed with us in Coding Clinic first quarter 2009. That coding clinic referred back to a coding clinic from a previous year, and we have the citation for that a patient presents with a stage 2 pressure ulcer, and during the hospital stay it progresses to becoming a stage 3 pressure ulcer. This guideline, this coding clinic tells us that this present on admission indicator is reported as yes for this ulcer, and that frankly flies in the face of the guideline that we've just looked at. It appears inconsistent. The individual who submitted this question correctly points out that it appears inconsistent to report a stage 3 pressure ulcer as present on admission, since it was not and progressed to a stage 3 during the hospital stay. And this questioner asked Coding Clinic to please clarify this specific guidance. And here's our answer. In terms of coding and POA reporting, a pressure ulcer is only coded and reported once at the highest stage during the stay, and that we understand. And this information is consistent with the previous Coding Clinic guideline as we discussed. The pressure ulcer was present on admission and therefore should be reported as yes. And they're kind of taking a roundabout way of telling us that the focus is on the ulcer's presence and not the stage. And the reason for this is explained to us that this advice is consistent with an organization that had considerable influence with the cooperating parties in getting this established, the National Quality Forum, and who established standards for reporting serious reportable events, also called never events. And I think really the bottom line here is that generally patients who have serious pressure ulcers, they may arrive with a pressure ulcer, but given the comorbidities that exist, there's not much that can be done to prevent the progression of that pressure ulcer, and therefore they've chosen to have this reported as present on admission as yes rather than no. So there we have that. Just wanted to show you very quickly the previous 2008 Coding Clinic, and the language there looks exactly like the Coding Clinic that we just looked at. Assign yes to the pressure ulcer stage 3, since this code is referring to a pressure ulcer that was present rather than a new pressure ulcer that was not present on admission. Okay. On the topic of pressure ulcers, an associated procedure is often the debridement, and a very important coding clinic given to us in third quarter 2015 helps give us direction in coding debridement procedures. And the questioner asks, can you clarify what determines that a debridement in ICD-10 PCS is excisional? They give an example stating, I have debrided something, and their example says by sharp debridement. And the questioner asks, does the word excision need to be present as it did in ICD-9, making the point that sharp does not equal excision for documentation purposes? And the answer is, quite clearly, a code is assigned for excisional debridement when the provider documents excisional debridement, and that is that. The words sharp debridement are not sufficient. Folks have asked about the word removal, and the word removal is even a bit vague in and of itself because tissue can be removed in a variety of fashions. So in fact, the gold standard for reporting excisional debridement, according to Coding Clinic, making it quite clear, and I think this Coding Clinic is even clearer more clearly stated than it was given to us in ICD-9 that the term excisional is essential for use of the root operation excision. So there you have it. But this is a quite clear explanation of how to meet the standard, the documentation standard for excisional debridement, and there's really no getting around that one. This one is quite clear. Next, I would like to talk a little bit about a range of new entries in the ICD-10-CM index. Something we did not have in ICD-9 was an entry for deep tissue injury, abbreviation DTI, which is a synonym for pressure ulcer. And when you go to the index, you see, this is a snapshot of the index at the bottom of the page, the term injury, and the subterms are deep tissue, see contusion by sight, which is not helpful in this explanation, but the term deep tissue injury meaning pressure ulcer, and the instructions there are quite specific. It says see ulcer pressure unstageable by sight. And of course it's unstageable unless of course you have statement of a stage, but that gives you a direction to go in. What's interesting here is the use of the index, use of the term meaning, because generally we don't get into what trying to be clairvoyant and understand what someone meant by a certain phrase. But the term meaning, and I know that you're going to go use Control F and check your online index to see how many times the word meaning appears in the index, and I recommend you do that. But it arises in certain situations like azotemia meaning uremia, or septicemia meaning sepsis. So it does give you a little bit of license to translate what the clinician meant by the phrase, example here, DTI, meaning a pressure ulcer, which is quite often the synonym that is used there. So I just wanted to bring that to your attention to kind of round out our discussion of pressure ulcers, POA indicators, and excisional debridement. The next index entry I wanted to bring to your attention is that which is new this year under postoperative. So if you're given the term a postoperative, whatever the condition might be, a the non-essential modifier being post-procedural, the instructions there are quite clear. It says C, complication postoperative. It doesn't say C also, it says C, a very direct and inflexible instruction, telling us that the ICD-10-CM now equates postoperative, a condition's relationship in time to the procedure, to a complication that is postoperative. And we're going to look at a little bit, an example of that a little bit later, but I wanted to just point this out because this is an index entry that many were not familiar with. And as we head into the next coding clinic, I'm going to start with a new index entry, and this is a snapshot of that index where it says disorder. This is the extrinsic circulating anticoagulant disorder of an extrinsic and drug-induced. There you have that. Before we talk about that, this is the new index entry. This is difficult to find. And this is really bleeding disorders that are caused by anticoagulants. This entry is difficult to find. You will not find it under the main term hemorrhage. You will not find it under the main term bleeding, and that's why we bring it to your attention today. So there. And as we jump into the question, this is really a coding clinic being educational with respect to a new code that exists in 10 that did not exist in 9. Reporting bleeding disorders in ICD-9 was very unsatisfying because there really was no way to do it without using a symptom code. I think it was prolonged bleeding time and perhaps an adverse effect code depending on your approach. But here, this coding clinic helps us understand the right way to utilize this code D68.32, hemorrhagic disorder due to extrinsic circulating anticoagulant. What's the correct code assignment for a duodenal ulcer with hemorrhage due to Coumadin therapy and initial encounter? And the answer is really quite revealing. It tells us to assign, as you would expect, the duodenal ulcer, K26.4, and D6832, the hemorrhagic disorder due to extrinsic circulating anticoagulants. And the answer also tells us to use an adverse effect code for the anticoagulant. Instructions then go on to tell us that depending on the circumstances of the admission, it may be appropriate to code to sequence either the ulcer or the circulating anticoagulant first, depending on what was done. If perhaps a procedure was done due to control the bleeding at the site of the ulcer, then it's likely you would use the ulcer code. But if this was in fact a means of correcting the coagulation, perhaps a heparin bridge to Coumadin, then it would be appropriate, I would think, to use D6832 as the principal or first listed diagnosis. And the instructions are quite clear that the adverse effect code is assigned for bleeding resulting from the anticoagulant that is properly administered. Hemorrhage the next question, should bleeding due to therapeutic anticoagulant be coded as a hemorrhagic disorder? Kind of approaching it in a more broad way, but addressing the exact same question. It goes on sort of a clinical discussion. For the most part, a hemorrhagic disorder or coagulation defects must be specifically diagnosed by the provider, and that is not hard to find in the record. Providers generally quite clear point out that the bleeding is likely to have been caused by an adverse effect, a side effect of the anticoagulant. The next paragraph tells us that the code D6832 should be assigned and that this is supported by the inclusion term at D6832, which we will look at in a moment. And the sequencing is again dependent on the circumstances, and the additional code for the hemoptysis, the hematuria, perhaps the soft tissue hematoma, or the rectus muscle sheath hematoma as a result, would also be assigned as a code. This is the snapshot of the tabular, and here you see the inclusion terms. Drug-induced hemorrhagic disorder, disorder due to increased anti-2A, anti-XA, which are anticoagulants that have different mechanisms. They are referred to in that way, and hyperhepaриnemia, and the instructional term inflexible, use an additional code for to show the adverse effect. Just a quick note, I'm going to go back quickly to show you the inclusion term at D6832. Folks were a little bit confused by that phrase because some thought they were saying inclusion notes and said that in fact there are no inclusion notes. But to make the point, the difference between an inclusion note and an inclusion term. Inclusion note, some examples, whereas inclusion terms may be synonyms, and that the list of inclusion terms is not necessarily exhaustive, meaning that you don't necessarily have to have the exact language to use that. So the inclusion terms is helpful knowing that you're at the right place and using the right circumstance. This next coding clinic is actually very enlightening. This is a patient that underwent an emergency ileocystectomy. The patient's stay was complicated by a postoperative coagulopathy and an intra-abdominal hemorrhage due to prasugrel, an anticoagulant, and aspirin taken as prescribed prior to admission. And the fact that they tell us that this is an emergency procedure tells us that there was no time for reversal of the extrinsic coagulopathy that caused by the anticoagulant. And the answer is, as you would expect, D6832, the hemorrhagic disorder, the adverse effect of the anticoagulants, one code for the prasugrel, the other for the aspirin. But keep in mind, they're also telling us to use K91.840, post-procedural hemorrhage and hematoma of a digestive system, organ, or structure, specific to the GI system. And this is related to the index instructional term telling us that it was a post-procedural hemorrhage and that it is to be recorded according to the index as a complication of the procedure. And here at this point, we're going to take a moment, and Ray Ellen has some thoughts to share with us.
Thanks, Barry. So for folks who have a MediReg subscription, I want to take you into the coding suite to show you where to get to the resources that Barry is talking about. Can you see my screen now, Barry?
Yes, I do.
Okay, great. So I'm demonstrating from the Audit and Revenue Resource Center because I want to point out that under Code Books and Guidance, you'll see your coding clinics are right there. And we have kept the ICD-9 coding clinic archives in alongside of the ICD-10. And just as a benefit to subscribers, we did add the American Hospital Association ICD-10 handbook 2-year subscription. So if you have the coding clinics, you also have the handbook. And I've heard from lots of folks that what's helpful about the handbook is when Nellie wrote that, she sort of assumed we were already an I-9 specialist, which kind of helps you figure out where to change your brain when it's quite different. So one of the main tools that I use to do ICD coding research is ICD Explorer. And so I'm just going to follow up on the last slide that you were talking about, Barry, and show you how to use this tool. It will allow you to search 9s and 10s, diagnoses and procedure codes at the same time. You can alter your selection here. So for instance, if I turned off the other codes, I would only see my ICD-10 CM result. And then you're going to see the indenting that you would normally see in the book. And the bolded codes are the ones that are reportable, just to make sure that you don't get confused. So you can't report a D68.3 because it's not precise enough. You need to go all the way to the 6th character. The green button is the mapping button if you do want to access GEM. But what's more interesting now that we've migrated to I-10 are these hyperlinks right here. So if you click into the code book, you're going to get to our electronic code book. You can put a page, you can bookmark it. We will move your bookmarks for 2017 for you when we roll over to the new code book. Or more appropriately, we'll put the 2017 info right on this page. When you get to this screen, it's important to make sure you expand the chapter and section instructions. That would be like flipping to the front section of that chapter in the book, where you might see includes and excludes notes that apply to all the codes in this particular chapter. And in the case of D65 through 69, there is no section instructions, but if there were, there would be a little plus sign there. And then sometimes when we are coding and you search and explore, it's going to show you a limited list of codes based on your search terms. And you might want to come into the actual book and see the entire list of reportable codes. And if you've gone to a fracture code, for instance, that might be a huge list. So you do have the opportunity of collapsing the book, and then you'll see every 4th digit specificity, and anyone that requires deeper specificity will have a little plus sign next to it. You can walk your way into your diagnosis codes that way if you prefer. The other links that you're going to notice from ICD Explorer really streamline your research. So if you're curious if there's any coverage determinations related to this disorder, you can click on the LCD link. Notice that this searches for codes that start in the same family. So it could be D68 point whatever. And there you're pulling up whichever payers you have, as well as national coverage determinations, lab coding instructions, and so on. And then you can also very quickly access the DRG definitions manual. So I happen to know that D68, when it's a principal diagnosis, is going to get you into MDC-16 and DRG-813. So that's very nice to see, quick and easy, so you understand how the grouper would behave. If it's the secondary diagnosis, you can see down here which codes fall onto the CC, and or if there were, you would see the MCC list here. And then I also see some hits down here in MDC-16 other disorders. And then these blue links hyperlink you right back into the ICD-10 code book. So you kind of got a circle where you can go from ICD Explorer into the DRG definitions manual back into the code book. And then finally, there's a guidance link. And that searches a custom library related specifically to coding. And that's where you'll automatically get your coding clinic results. So Barry was just talking about 2016 Volume 1. You can see your terms highlighted. You can open the PDF from here. When you search in the guidance library, you might also get lucky and find interesting transmittals, MLM Matters articles, and things of the like, national coverage determinations, etc. And also you'll notice that in addition to that one page you found in the code book, it is often useful to search the rest of the code book. So here's the page for D68, which I already showed you. But then the term D68 shows up in a bunch of other places. So you're able to see those codes, those sections. If there were specific discussions in the guidelines, you'd see them here. And then also you can get into the index. Now, Barry, you were talking about the index. It's organized nicely in the code book, so you can code from the index or the tabular section. I just want you to know that our developer got quite frustrated because sometimes there are these C notes, and then when you go to that location, it tells you to go see something else, and then you go to that third location, and it can get a little circular. And that's not Betty Wright doing anything wrong. That's just how it was published by the CDC. And we hope that they clean some of that up when they publish the 2017 updates. I have one more minute. So I also just want to point out that in your subscription, we've made an electronic book out of the IPPS rule. At the bottom of that, you'll see the download center, which has all the data files and tables, and that's going to include the table 6s. There's a bunch of 6 tables, all that have the changes to the CC list. So here's the new procedure code, here's the new diagnosis code. You've got all of that. And then we're keeping a close eye on the Center for Disease Control to see the updates to 2017 for the ICD-10 codes. Those are kind of trickling out as we go. So that's just a quick review. And also your What's New will automatically update you when we've updated Coding Clinic, when new ICD-10 information is out, when your local coverage determinations are updated, and so on and so forth. So do keep an eye on that What's New to catch that next latest, greatest thing that you need to comply with. So I'm going to go back to Barry as the presenter.
Okay, thank you, Ray Ellen.
Sure.
Right now, you're looking at a slide that says heart failure. Is that true?
I see it.
Very good. Okay. Just making sure we're all in the right place, especially me. Next, we're going to talk about heart failure, and this next collection of coding clinics may get the award as the best coding clinic ever, and it works like this. It's entitled Heart Failure with Preserved Ejection Fraction or Heart Failure with Reduced Ejection Fraction, and this is one of those empowering coding clinics that we talked about before. It allows the coder to take some information in the record and without having to query, make a decision and assign a code. It starts out asking Coding Clinic to reconsider some previous advice. And you'll notice a theme where as we learn more about how to use 10, we and you as users become more sophisticated and have insight and questions to ask. It talks about the previous Coding Clinic saying that the coder cannot assume diastolic or systolic failure based on the abbreviations HF, PEF, preserved ejection fraction, or REF, reduced ejection fraction. And the question is it appropriate, the question asks again, is it appropriate to code diastolic or systolic heart failure in the presence of this documentation? And the answer is, we've got an input from the American College of Cardiology, and based on that, the Coding Clinic cooperating parties, the editorial board, has reconsidered the previous advice and is now telling us the following, that HFPEF, heart failure with preserved systolic function, equates to diastolic heart failure. And the opposite, HFREF, reduced, also meaning systolic heart failure, may now be reported as systolic heart failure. And this is a big change in our ability to make some decisions, and will cut down on a huge number of queries. We have further information that tells us, therefore, when the provider documents these two abbreviations or other similar terms noted above, the coder may interpret these as diastolic or systolic respectively and assign the appropriate ICD-10-CM codes. This is a huge step forward. And while that coding clinic is worded in a very specific way, I've given you some shorthand. You may want to just cut this out, hang it over your desk until you get this one under your belt. But this is really the translation that occurs. HF, PEF, HF, REF, diastolic and systolic, respectively. Okay, big improvement to our decision process given to us by the editorial board. I think kind of a big thank you for that one. Next, we're going to talk about diabetes and associated conditions. This is a big improvement, I think, over ICD-9 as well. With respect to guidance, this guidance is very clear. Question tells us that diabetes with, the index is structured differently for diabetes and associated conditions in a manner that was not the same as it was in 9. And the question is, does the provider need to document a relationship between the two conditions, or can the coder assume a causal relationship? Answer. Quite simply, a little description of what due to or with means, and telling us that these phrases now mean it's meant to be interpreted as assigning codes for diabetes when associated. The classification assumes a cause and effect relationship between diabetes and certain diseases of the kidneys and nerves and circulatory system. Big step forward. So with that information, we go on to the next slide, which of course complicates it a little by saying if the physician specifically tells us that diabetes is not the underlying cause of a condition, then obviously it should not be coded as a diabetic complication. And this paragraph, you'll recognize, is actually very much like the obstetric guideline that tells us that all conditions of a pregnant individual are complications of the pregnancy unless the physician tells us otherwise. And here, this is telling us that all conditions associated with diabetes are complications of diabetes unless the physician tells us otherwise. And the paragraph at the bottom just goes on to tell us that if there's any uncertainty, that one should be querying a physician. I've inserted here the specific guideline that this coding clinic references. So this is a situation where coding clinic actually works in concert with the guidelines, telling us that the word with should be interpreted to mean associated with or due to when it appears in a code title. And therefore, that's how we reach the conclusion that we are coding the clinical information as a complication of diabetes. The answer goes on to provide a little bit more information, but the second paragraph is really, however, the provider needs to document the linkage except in situations where the classification assumes an association such as diabetes, or such as the example we're always familiar with is hypertension with chronic kidney disease. So really think of diabetes with as hypertension with, that when they coexist, they can be coded together as complications of, and that's really a big step forward for this coding clinic. This coding clinic is supported by the following question. A patient who's a type 2 diabetic admitted with a chronically infected ulcer of the left midfoot. The easy part is that the provider is documenting this as a diabetic foot ulcer with skin breakdown with methicillin-resistant Staph aureus. Okay? However, we also have information that the patient is diagnosed with polyneuropathy, a frequent diabetes complication, end-stage renal disease, a frequent diabetes complication, and is on hemodialysis. And the question, as you would expect, is, does diabetes assume a cause and effect relationship between these three conditions? Specifically, as always, how do we code the case that you've described above? The answer is ICD-10 assumes a causal relationship between the DM, the ulcer, the polyneuropathy, as well as the chronic kidney disease, driving home the point that was made in the information in the previous coding clinic. The codes that would be reported, as I said before, because it's called a diabetic foot ulcer, E11621, easily determined. You have the additional code for the ulcer, but you would also use E11.42, diabetes complicated by polyneuropathy. You have the additional code to describe the organism of the ulcer, and E1122, diabetes with chronic kidney disease, and the additional code for chronic kidney disease and the dependence on renal dialysis. This coding clinic driving home the point that, as phrased, the patient with the diabetes and the neuropathy and the diabetes and the end-stage renal disease, they are now reported as complications of the diabetes. And of course, as you might expect for any guideline and guidance that we're given, there are exceptions to that. And here we have the coding clinic from fourth quarter 2013, raising the question of a previous coding clinic in ICD-9 that assumed a relationship between diabetes and osteomyelitis when both conditions are present. And the question is this same relationship between diabetes and osteomyelitis true for ICD-10? And I remember the day I read this one, I was floored to realize that this coding clinic was in fact telling us this is not the case in ICD-10, that ICD-10 does not presume a linkage between diabetes and osteomyelitis, and that the provider will need to document the linkage before those two conditions can be reported as such. And I think this really helps to solve the problem that arose whenever we had diabetic patients with sacral pressure ulcers that progressed to osteomyelitis, because in that instance, the osteomyelitis was related to the pressure ulcer and not necessarily associated with the diabetes. But the guidelines were pretty sure that a patient that had diabetes and osteomyelitis needed to be coded as diabetic osteomyelitis, even if it seemed that was not the case. So keep in mind how this coding clinic guidance would affect our decision process there. Next, we have the topic of diabetes type 2 with ketoacidosis, and the question is simply, how do we code this condition, type 2 DM with diabetic ketoacidosis? And here the answer is E1310, other specified diabetes with ketoacidosis without coma for a patient in this situation. And it goes on to tell us that given the less than perfect limited choices, it was felt that it would be clinically important to identify the fact the patient has ketoacidosis rather than the type of diabetes which we could not report the ketoacidosis. This second paragraph that's bolded tells us that in fact in the creation of the classification they forgot to give us a code for type 2 diabetes with ketoacidosis, and that what they preferred was that we, as you can tell, E13 is other specified diabetes, not E11 for type 2, giving us, it's really a situation where they forgot to put the code in and that they've created a solution so that everyone doesn't all go off and decide all willy-nilly to create their own solution to this reporting dilemma, and then I'll use the same incorrect answer until we have the correct answer, which leads us to the point that the correct answer will be given to us not this year in fiscal year 2017, but it's slated to be given to us for fiscal year 2018. Now that could change in the final table of new codes being given to us, but at the moment the decision was made at the Coordination and Maintenance Committee meeting that you can listen to the recording to, that this will occur not this year but next year. It's worth also pointing out that the original version of ICD-10 offered by the World Health Organization contained the code for type 2 diabetes E11.1, but somehow that code never made the transition into ICD-10-CM, the United States version. And while we're talking about diabetes, it's worth going back to the index and showing you a change there. At the bottom of the slide, you'll see that in ICD-9, the phrase poorly controlled diabetes in the index led us to the phrase code to diabetes by type with fifth digit state for not stated as uncontrolled. And that double negative tells us that poorly controlled diabetes was reported as controlled diabetes. Whereas in ICD-10, the improvement to the index tells us that we now have the phrase, the subterms in the index under diabetes for out of control, poorly controlled, and inadequately controlled to report it as diabetes by type with hyperglycemia, which makes a lot more sense and really improves what we can tell us about our patient population. And then we have the topic of diabetes with hypoglycemia. What about hypoglycemia? And in fact, in ICD-10, we have a distinct code for diabetes with hypoglycemia with and without coma. This is a big advance in the classification because, as you recall, in ICD-9, we could only report that to the catch-all code 250.80, which was diabetes with other specified complication. This is where you reported your diabetic osteomyelitis. This is where you reported your hypoglycemia and a variety of other kind of odd diabetic complications. One of the big changes to the classification, this is what obstetric perineal laceration repair in ICD-10 now has been given some specific guidance in ICD-10. This is one of those topics where they've taken the topic and they've given us a bit of guidance and a bit of coding clinic questions to help explain how they want it reported. Here you have a bit of a summary, and they're telling us now that if the root operation invoking guideline B 3.5 about the root operation for excision repair or inspection are reported on overlapping layers of the musculoskeletal system, the body part specifying the deepest layer repaired, inspected, or excised is coded. The example, second-degree laceration, perineal muscle, the deepest layer perineal muscle only is coded and not the more external layer. Let's have a look at how that works. And what this really is, that it's really telling us that the two guidelines that were in effect, we have the overlapping body layers, guideline B 3.5, but the one that many people used during our training and learning for ICD-10 in this category was the multiple procedures, whereas if the same root operation is performed on different body parts as defined by distinct body part values. And this will become more clear. You probably recall this from your education, but let's have a quick look. You may not have done it this way. But in the beginning, during our education process, this is how we coded, many of us coded, and that's why I use the phrase commonly coded, obstetric perineal lacerations. First degree, 0WQ, W being the anatomic regions, Q being the repair, N being the perineum. Second degree and muscle, 0KQ, K being the character for muscle. But when we got into third and fourth degree, following the B3.2 guideline and not the B3.5, many of us used multiple procedure codes to code third degree, showing that the second character, K, is for the body system of muscle, and the third character of D is the GI system representing the anal sphincter that was repaired. And for the fourth degree laceration, many of us used 3 procedure codes for the muscle and the 2 distinct areas within the GI system for the repair. But in fact, Coding Clinic is now giving us some very, some very specific guidance that they would like first degree perineal laceration coded as 0HQ9XZZ, repair of the perineum skin, external approach. And you can see how this is different than how many of us did it using the example I showed you previously. For second degree laceration, Coding Clinic and the cooperating parties would like this reported as 0KQ M0ZZ, and you can see that that's exactly how we did it previously. And the real difference becomes under third and fourth degree lacerations, where we using the other guideline would have used 2 procedure codes. Coding Clinic is telling us that we can be more efficient about our reporting and use the deepest layer guideline instead, 0DQR0ZZ, and for fourth degree laceration, using a single code instead of the 3 codes that we might have previously used. So keep that in mind. Now here the question to Coding Clinic is, the patient had a completely normal delivery except for an obstetric third degree. Is it correct to code? And Coding Clinic tells us to assign the deepest layer. And their defense is using guideline 3.5, and I have pointed out that it says for the deepest layer of the musculoskeletal system. And the real problem that folks have pointed out is that the deeper layers are not in fact of the musculoskeletal system, meaning character, I believe it's K, that in fact it is character D, meaning that you've gone into a different body system. Be that as it may, Coding Clinic is asking us to report these this way. It's an efficient way to do so, and that's really where we'd like to leave it, and that's the advice that I would like to offer to people to follow. And I realize I've gotten I'm a little running out of space, running out of time. My suggestion is that you take some time at the conclusion of the presentation and go through the remaining Coding Clinics. I've tried to front load the presentation with some of the more relevant and more interesting materials, and at this point, if we have any time, I think we may go to some questions, but if not, I apologize, and we'll certainly take your written questions and get back to you with written answers to things you might have questions about. So I'm going to turn it over to Ray Ellen for a wrap-up with either questions or conclusion.
Thank you, Barry. I do have a couple questions that I think you could answer on the fly.
Okay.
A patient has COPD with pneumonia. Would you use the combination code, COPD with lower respiratory infection, TNA code, and what is the recommended sequencing of this?
That's an interesting question. I would like to take, not to avoid answering the question, but I would like to, but I'm going to exactly do that until I can have a look at the book. And before I say something along the lines of perhaps both codes, I mean, pneumonia is a very precise type of lower respiratory infection, and therefore I'd like to just evaluate the available guidance before I answer that, if that's okay.
That makes sense. One person, and actually this question was asked in the last session as well, was asking for the guidelines for sepsis. So those can be found in the official coding guidelines on page 19 and on page 96. Yeah, that's a repeat. And then another one, in ICD-9, this is related to the hemorrhagic disorder. We were instructed, this person states that in I-9, we were instructed by Coding Clinic to use the symptom code and not 286.7, which is acquired coagulation factor deficiency. I wonder if you have a comment about that. This person seems to think
I believe the reason for that was that 286.7 was not specific to an extrinsic coagulation defect. Extrinsic meaning, as I understand it, caused by a medication, as opposed to intrinsic, which is a genetic predisposition to the condition.
Interesting.
And that,
Okay.
that was the basis for that coding clinic, I believe.
Okay, so those questions will appear in the study guide that will be available shortly. Thank you all very much for attending, and we will be sending you out a survey. When you complete that survey, you'll receive CEUs at the end of that, and we appreciate your time today. Have a great day.